And welcome. Here we go. Today we're going to talk about advanced pathophysiology and neurological disorders. So today is not going to be about like neurotrivia and stuff you need to know in case you get on a game show. The whole point of this session is basically in the subtitle, and essentially that is to say, I want you to be able to link the pathophysiologic mechanisms to clinical presentations, and it will guide your diagnostic approach. So you're going to go from link the mechanisms to the symptoms to the workup to the treatment. So as we move through the cases, I want you to constantly ask yourself the three questions. And those three questions are: what structure or pathway is broken? And how would that actually show up in the room in front of me in terms of signs and symptoms? And then, given that mechanism as to what is going wrong, what labs, imaging, treatment, or would actually make sense? And then what's going to basically be not worth the time and money to do this? So if you can answer those three questions by the end of this section, you're going to be thinking like an advanced practice provider, and that's going to distinguish how you're using and applying knowledge from your current RN role. So I'm going to show you some real patterns that you'll see in practice. We're going to talk about strokes, seizures, demyelinating disease, neurodegeneration, and we'll talk about some red flag emergencies as well. Now, for each disorder, we're going to cover the same path. We're going to talk about mechanisms, that is, what's happening at the level of neurons, vessels, myelin. And then we're going to talk about the clinical picture, why that mechanism gives these focal deficits, this mental status change, or that headache pattern. And then we'll talk about the workup, which tests the mechanism of the pathophysiology we're concerned with. And also then we'll talk about treatment, how drugs, procedures actually target the underlying patho. So that's kind of the roadmap as we progress through today. And as we get through these objectives, I want you to listen to each disorder with these four objectives in mind. They're going to apply to everything, okay? This is what's going to separate RN level from that of an advanced practice RN. First, you're going to figure out and listen for how do we apply mechanisms to symptoms. So every neuro symptom is a clue. Whether it's unilateral weakness, visual field cuts, intention tremor, aphasia. None of these symptoms are random. The point is to look at the specific neural structures, and then your job gets to be, how do I read this body like a map and let the mechanism tell you the differential? The second thing you need to keep in mind, regardless of disorder, is executing the right diagnostic pathway. So one of the problems or benefits of neuro, depending on your perspective, is that it is time sensitive. So for example, a confused patient with a focal deficit, you don't take a wait and see approach. That's activate the stroke protocol and let's move this along. You know, a first seizure, you need to be careful jumping to meds right away. Yes, stop the seizure, but you need to figure out, you need to get some imaging and rule out some structural causes. Okay. The mechanism of the patho is going to determine the test. Okay. Third, you're going to choose treatments that actually match the pathophysiology. Okay. So, for example, reperfusion works in a stroke because the problem is what? Impaired blood flow, right? Vessel occlusion or a bleed before the destination of perfusion there. So that's going to be important to figure out. Um, and then the other thing you need to keep in mind, for example, like certain anti-epileptics, they work because they target an exact ion channel that's involved. If we're talking about something like multiple sclerosis therapies, they work because it's an immune mediated demyelination. So the goal is that you'll be treating the mechanism, not the symptom. Now, the fourth thing you need to keep in mind is you need to be attuned to what constitutes a red flag before it becomes a disaster. So, neuro has a lot of mimics. So, for example, hypoglycemic coma can look like a stroke, or a complex migraine can imitate a TIA, or psychogenic seizures can fool you into giving somebody a benzo, i.e., the wrong drug. And your job is going to be to catch these dangerous patterns early so that you can avoid these classical pitfalls along the way. So, everything we're going to do today is going to flow from those four. So, keep them in mind in the coming slides. Okay. So let's talk about this. Let's start with stroke, right? Most common. So, because this is where the mechanism is driving the clock, when a vessel occludes, the brain basically splits into two zones. And a core that's already dead, and a penumbra that's injured but still salvageable. So everything we do in acute stroke is about saving the penumbra before it becomes core. Now, I'll define what these mean shortly, but basically, when you have ischemia, it means that no ATP is happening. The pump fails. You get cells that swell, and that leads to excitotoxicity, and then the neurons die. You don't need the entire cascade. Just remember, no blood flow, no fuel, neurons die. Got it? If you can't perfuse it, it's going to die. So clinical patterns will tell you where the deficit is. So depending on the symptom they show, you can work your way backwards and know where the occlusion is. So, like for example, a middle cerebral artery, you're going to see face and arm weakness, aphasia, right? Or neglect. If they have like a posterior cerebral artery, you're going to see visual field that's cut out. That's when you get the homogeneous hemianopsia, right? You go visually blind in a field. If you have a brainstem stroke, right, you're going to have cranial nerve deficits and cross motor findings. It's often severe. But those are kind of like bedside things. Where the deficit is tells you where you might find the problem. And so the other question you're going to ask is this a stroke and are we in a treatment window? One of the questions is, when was your last known normal, if you've ever called a stroke response at your facility? Once you call a stroke alert, imaging is going to guide everything you do thereafter. And the first test we always do is that non-contrast head CT. And the reason we do that is we're trying to rule out a hemorrhage because we don't want to be giving thrombolytics to someone who's bleeding. That's very bad. The next thing is going to be like a CT angio, and we're going to look for large vessel occlusion, and then CT perfusion or MRI, and that's going to distinguish core from penumbra. And goal is to restore perfusion most of the time. What do I say most of the time for? Well, I'll tell you. So take a look here. We're going to go through this a little slower. So because this slide is the logic behind every stroke decision you make, the first thing we need to start with here is blood flow. So normal cerebral blood flow, CBF, that's about 50 milliliters per 100 grams of brain per minute. Okay, so when that falls below about 10 milliliters per 100 grams, neurons can't maintain basic hemostasis, homeostasis. And so what happens, assuming you're bleeding out, we need hemostasis. But what happens now is they run out of ATP, the ion pump fails, and then the cells swell up and then they die within minutes. Now, on the diagram here, that innermost dark circle, that's supposed to represent the core. That's the tissue where the cerebral blood flow is already below the 10 range that I talked about. That core is irreversibly infarcted already. So no thrombolytic and no mechanical thrombectomy and no blood pressure trick is going to bring that tissue back. So the next outer layer, that pink ring around the red, that's what we call the penumbra. And here the blood flow is reduced to 10 to 20 milliliters per 100 grams per minute. It's not enough for normal firing, so the neurons are electrically silent and clinically weak. But the good news is they're still technically biochemically alive. They're running on some sort of backup generator, and they can hold on for a while, but not forever. So in acute ischemic stroke, your primary question is how much penumbra is left and how fast can I save it? Whether the penumbra survives depends on four things. So penumbra survival depends on the occlusion site. So like a clot in the middle cerebral artery, that's going to cut off a huge wedge of the cortex. So a tiny distal branch occlusion affects a much smaller territory than, say, such a large artery. The bigger the territory, the bigger the core, and the bigger the penumbra. The other thing it depends on, occlusion site, the second one is collateral circulation. Now, the older you are, the more collateral you get to build up. So some patients have rich side streets of blood flowing from neighboring arteries. Those collaterals can keep the penumbra alive for hours, so it buys you time. Other people have bad collaterals and they convert to core very quickly. The third thing that affects salvation of the penumbra is the system blood pressure. So this is why neuro will let pressures ride up a bit in the acute post-stroke phase because they're trying to perfuse penumbra. The penumbra lives on the edge. It depends on every bit of perfusion it can steal. So if the blood pressure drops, that fragile zone is going to collapse into core. And we don't want the penumbra to become core because core is irreversible. And finally, the fourth thing we need to keep in mind is time from symptom onset. So as minutes pass, that pink ring is going to shrink and that core dot, that red dot, is going to expand. Okay? It's not just a slogan that we put on the stroke posters that time is brain. Time really is brain. So take a look now at these clinical implications. So our modern imaging is built to visualize exactly what you're seeing in this diagram. So the CT will tell you about brain perfusion. The MRI will tell you about diffusion perfusion mismatch. So this is going to tell you this part is already core and this part is still penumbra. And here is the amount of tissue we could still rescue. That's what the MRI is telling you. Now, if the imaging shows you a small core and a large penumbra, you're going to push really hard for reperfusion, whether that's TPA or if it's large enough, a mechanical thrombectomy, if it's a large vessel. But if the imaging shows you that the whole region is already core, then reperfusion is not going to restore function and it may increase the risk of hemorrhage. So the goal is not going to be to thrombolyse these people if they're too far along. That's why time is brain. So in this case, your job is going to shift merely to supportive care and secondary prevention, not opening the blood vessel if you're too far along. So you're not just treating the symptom, you're racing against the clock in issues of ischemia of the brain. You're treating that physiology of the penumbra. So in acute ischemic stroke, your only goal is to rescue viable brain before it crosses that line and becomes core injury. So we're going to walk through now this inflammatory cascade as it relates to the brain. This is how ischemia triggers it. So what happens is this is a molecular disaster, essentially, that's unfolding the moment the blood flow drops. So if you get this slide, you're going to understand why the patient's neuro exam worsens minute by minute and why all the interventions are so time sensitive. So we start here with ischemia, that's inadequate blood flow, and immediately that's going to lead to ATP depletion because neurons depend entirely on oxidative metabolism. So once the ATP drops, that sodium potassium pump fails. And that pump is what maintains the neuron's resting potential. Well, when it fails, the membrane becomes depolarized and ions will move the wrong way. Now, depolarization triggers massive glutamate release. And those of you in the psych program that know that glutamate is the excitatory neurotransmitter, right? And too much glutamate firing on the receptor is was not meant to be. So that's what we mean by excitotoxicity. It's too much glutamate firing on the receptor. Now, glutamate stimulates NMDA receptors, and that opens up the ion channels and allows calcium to rush into the cell. Well, calcium is the final common pathway of neuronal injury. If you think about it, in order for calcium to be high in the serum, that means it had to leak out of the cell. And if it's leaking out of the cell, that means the cell has ruptured and died. That's why you see the calcium start to go up. So this activates proteases, which destroy structural protein that overwhelms the mitochondria. The mitochondria, which is the powerhouse of the cell, fails. That generates free radicals. You get reactive oxygen species damage. It damages the DNA, the lipid membrane, and once you get to that point, the neuron is marching toward apoptosis. Apoptosis is programmed cell death and necrosis. That concept of apoptosis, I have a feeling, will be tested on the HESI, so pay close attention to that. Now, the core is the part that is dead, the necrotic part. So the big message here is this is a cascade that is self-propagating and accelerates over time. So that's why fever and hyperglycemia might make this cascade worse. Why would that be? Well, fever and hyperglycemia increase metabolic demand and oxidative stress. Normothermia and euglycemia, even small corrections will protect the brain. That's why we want to have to control the blood sugar in these critical care situations. So time is brain. That's the literal speed of this cascade of events. So therapeutically, your only proven way to interrupt this cascade is reperfusion. All the drugs are designed to block individual steps. Anti-excitotoxic agents, free radical scavengers, still under investigation. So what you're seeing on this slide is the reason we rush to CT scan and the reason every minute matters. And the reason that stroke care is basically about rescuing tissue from this molecular avalanche. So let's take a look here from the molecular level back to the bedsides, because this is where mechanisms will meet your neuro exam. So this is a table that's like the Rosetta Stone of stroke localization, essentially. Now, if you can recognize these patterns quickly, you will hopefully never miss a large vessel stroke. So let's go territory by territory through this. So pay attention here to that middle cerebral artery. This is the big one, okay? This is the most common large vessel occlusion. When the MCA is blocked, the cortex controlling the face and arm is most affected. So what might you see? Well, you'll see a contralateral face and arm weakness more than leg weakness. You will see aphasia if it's the dominant hemisphere, meaning left dominant. That's where the aphasia is. You will see neglect if it's the non-dominant hemisphere. That's usually right dominant. So this is telling you, based on the deficit, which hemisphere is dominant for the patient. This is the one that will give you that homogeneous hemianopsia due to this optic radiation involvement. And what you should note here is a proximal M1 occlusion produces the most devastating deficit because they wipe out an entire hemisphere of blood supply. Now, look at the anterior cerebral artery here. This feeds the medial frontal lobe. And this controls the legs and initiation of action. So the classic pattern here is a contralateral leg arm weakness. Contralateral leg more than the arm, whereas in the MCA, it was arm more than the leg. So you'll also get this abulia. Abulia is a profound lack of a profound apathy or a lack of initiative. In an ACA, you may also see urinary incontinence from medial frontal involvement. Um, Isolated ACA occlusions are uncommon because the circle of Willis usually provides a good collateral flow. Posterior cerebral artery here, the PCA, this supplies the occipital lobe and part of the thalamus. And this will give you a very specific pattern of the hominominous hemianopsia. So this is essentially alexia without agraphia. So alexia means they can write but not read. And visual agnosia. So they can't tell what they're seeing exactly. You'll get memory impairment if the thalamus is involved. And you can also get cortical blindness with bilateral posterior cerebral artery strokes. Now, sometimes patients will even have visual hallucinations. The brain will just start to fill in the missing inputs. So this is why you can have a patient with a visual field deficit and they may never know it until they actually do a visual field test. You're like, wow, you don't see this whole right side of your the lateral side is gone for you. That's kind of a big deal. But they don't know it because the brain will just fill it in. Basilar artery, this is a life or death territory if you occlude the basilar artery. This can cause, this knocks out the brainstem and can cause quadriplegia or coma or locked-in syndrome. I currently have two patients with this. Their basilar artery, though, was not ischemic. It was hemorrhagic. They bled from their basilar artery, and one has a locked-in syndrome. Somehow one was able to regain some function, but severely advanced dementia. Needs a lot of support. So the patient in this case is fully conscious, but unable to move anything except their eyes. And mortality is extremely high for this. And it can, the thrombectomy window in this, because it's so large, extends up to 24 hours because the brainstem tolerates ischemia differently. Another one here, the last one on our list, is the lacunar strokes. These are small penetrating vessels. These are tiny strokes from small vessels, often due to poorly controlled hypertension or diabetes. These are often precursors to what can become vascular dementia. They don't cause cortical signs. There's no aphasia. There's no neglect. Instead, what you'll see are things like a pure motor hemiparesis or a pure sensory stroke, or they may have ataxic hemiparesis or dysarthria or a clumsy hand. These symptoms map to the deep structures like the internal capsule, the thalamus, and the pons. So what do I want you to take out of all this basically is some key signs and symptoms. Isolated hemianopia, think posterior cerebral artery. If they're aphasic, think that they're dominant middle cerebral artery. The more proximal the blockage, the more devastating the exam. So this is where the neuro exam can help you localize as a shortcut to the correct vascular diagnosis. Now, does this happen in real life? Is this just purely academic? In general, yeah, because you're going to CAT scan anyway, and then followed by MRI, and it will tell you all of this. But this is to give you an idea of, does the deficit match the symptoms you're seeing? That would be like us not teaching you how to listen to heart sounds because you could just get an echo on everybody. We don't do that. You still should know what the physical exam should look like prior to ordering a test. So before we go any deeper into stroke management, we need to ground ourselves here in what is not a stroke that might kill the patient faster than a stroke, and it sometimes looks like a stroke. So these are stroke mimics. These are lookalikes that you have to keep in mind. So The first one on the parade here is up to 30% of suspected strokes are actually something else. And the trick is you cannot think your way into certainty at the bedside. Whatever, if you think it's a stroke, activate the stroke team, call the stroke protocol. You want to rule the mimics out quickly because time is valuable, but you also should know that 30% may not be a stroke, but I'd rather you get them on their way than risk time is brain. So hypoglycemia is one of the simpler ones, but it's also the most dangerous. A low glucose can give you focal deficits and aphasia and altered mental status. So when you call rapid response in the stroke team, someone should run for the glucometer and check it at the same time because that's a fast one to fix. That's why point of care glucose is always a first test in someone that looks like they're having a stroke. And then also seizure with Todd's paralysis, that's post-ictal weakness. So after a focal seizure, the affected limb can stay weak for minutes to hours. So the clue is often a post-ictal period that was a witnessed seizure, but not always. And if you can't tell, activate the stroke team, we'll figure it out. Migraine with aura, visual phenomena, numbness, tingling, especially in younger patients, especially if they're on oral contraceptives, you might think stroke, but it could be migraine with aura. They're typically positive symptoms. They may talk about flashing lights versus the negative symptoms of a stroke, which would be vision loss. So usually if it's flashing lights, it's probably migraine with aura, but we can't be sure. We're going to activate that stroke team. Functional neurological disorder, you'll see an inconsistent exam. That's the giveaway. Weakness or non-anatomic patterns. This is covered in psychiatry. This is where the person just develops neurological symptoms that are not explained by objective diagnostic tests and they don't follow the normal anatomic patterns. It's a psychogenic condition, but if they put on a good show, you can think they're having a stroke. Also, Bell's palsy. This is an isolated peripheral facial nerve palsy. Unlike a stroke, Bell's palsy affects the whole half of the face, including the forehead. You can check out my paper on this glycemic glycol intoxication causing cranial nerve deficits, which cause that anion gap. What happened here was the patient developed a facial nerve palsy on a weekend. They called the stroke team, CAT scanned him. They said, nope, it's not a stroke, and then dismissed him, diagnosed and adios, because he's in psychiatry. I came back Monday morning. I'm like, well, it's not a stroke. Did they say what it was? Because the face is drooping. Yeah, but it's not Bell's palsy because it's not the whole face, only part of it. Interesting. I walked my dog, ran into the radiologist across the hall. He's like, well, we have an MRI with internal auditory canal protocol, which will illuminate the cranial nerves. And I was like, oh, cool. Let me check that out. Suffice it to say, we did it. He had some oxalate crystal deposit from the antifreeze he tried to drink when he tried to kill himself. And so this is a 19-day late effect of glycol intoxication. I'm like, that's very interesting. Let's write that up as a case report. So I did, and it's out there. And the reason it was interesting is because they gave him high dose steroids, assuming it was Bell's palsy. He was already getting ECT, so even if he got manic, we were going to buzz him through the mania. And the facial nerve deficit actually resolved. I happened to see a social media post of him years later smiling, and the smile was symmetrical. I'm like, aha, it still worked. That's how I knew from years later. I don't know what happened after we discharged him, but suffice it to say, it resolved his facial nerve deficit. Now, here are some red flags to pay attention to. So red flags for hemorrhage, the opposite side of the danger spectrum. So these symptoms should immediately shift your thinking towards intracranial hemorrhage. If they have a sudden severe headache, also known as the worst headache of their life, that is the classic sentinel bleed or subarachnoid hemorrhage sign, okay? That might appear somewhere that any nurse practitioner should be able to think, oh, might you be having a subarachnoid hemorrhage? Okay, it's the worst headache of your life. Another one that's concerning is if someone's vomiting, especially if it's projectile vomiting, because that means something has raised that intracranial pressure and it's causing this projectile vomiting. Also, if you notice a rapid decline in consciousness, bleeds deteriorate early. Ischemic strokes take a little time. Also, if they're having a hypertensive crisis, So what was the definition of hypertensive crisis from the cardiovascular lecture? You might see it again later on, making this test a cumulative final, but suffice it to say an SBP of greater than 220. Hypertensive intracranial hemorrhage is a major cause of bleed. And then finally, remember that for TPA and the like, the pressure needs to be less than 185 over 110. You need to control the pressure a little bit. So if you're ever torn between if this feels like a stroke, but this could be a mimic, what do? Call the stroke team, work it out later. Don't lose time debating because brain time is brain. So let's put this all together. Don't just think you need to act. That's the drive home message here. So if you're outside the hospital, EMS activate the stroke team. This is before the patient even arrives. They can call ahead. CT. Now in New York City, we have a couple of mobile CT scans, so they can scan you on site in some places, and then they can give you the thrombolytics right in the ambulance on the way over to the hospital. First 10 minutes, the goal is rapid stabilization, ABCs, drop an IV, do the stroke scale, and what you're looking for is the last known well, LKW, last known well. That's the most important timestamp in the entire workup. When was they last normal? Everything else fits around those data points. Airway, breathing, circulation, point of care glucose test, the National Institute of Health stroke severity scale, and the last known normal. You should just memorize that if you're going to work in pre-hospital or rapid response. Just memorize that. The third thing is by 20 minutes, they need to have had a non-contrast head CT. The sole purpose of that is to exclude hemorrhage. That will tell us if TNK and TPA are still on the table. It's not just bleeding. This is simply about, is it bleeding or not bleeding? That's all we want to know with that first non-contrast head CT. And then your question is going to be, if the CT rules out a hemorrhage and the patient has a persistent neurological deficit, which fits ischemia, we're going to start having a reperfusion decision. And hopefully by this time, neurology is involved in the case to help us decide that. All right. That's all I want you to see here. Yeah, that's good enough for this. Okay. So let's talk about the different imaging and why we do it. So this is the backbone of stroke decision making. Every modality on this slide is going to answer a different question. So your job is to know which question you're asking. So let's go line by line here. So non-contrast head CT scan. This is the first image always, and this is the time to acquire under 5 minutes. And the main purpose of this is to rule out a bleed. If the non-contrast CT is clean, you now have permission to think about TNK. I see 2 questions in the chat here. So CT angiography is number 2 on this list here, vessel imaging. So think of CTA as your map of the plumbing. It tells you what vessel is blocked and how big the clot is and whether collaterals are compensating. CTA is essential for identifying the large vessel occlusions. The patients who may need a mechanical thrombectomy on the slide image, you see vessels with a red blockage, okay? That's what a CTA is designed to highlight, large vessel occlusions. The other one here is the CT perfusion, core versus penumbra. CT perfusion quantifies for you the blood flow and the transit times, showing you the core, which is what? Dead, and the penumbra, which is salvageable. Okay, so this is where Dawn and Diffuse 3, which are the trials you read about, hopefully, if you did any of the reading, allows you to treat patients up to 24 hours if they still have penumbra. And that's what the image on this slide is showing you here. That red inner core versus the light outer pink ring, that's exactly what the CT perfusion is trying to tell you. And then finally, you've got the MRI here with diffuse weight, intensity, and flare. The MRI is the most sensitive for small infarcts, early ischemia, posterior circulation for strokes and stroke mimics. Diffuse weight imaging, this lights up for acute infarct. And if you see flare, that's going to light up for subacute changes. Why do I tell you this? Because you will be reading these MRI reports. This is going to be telling you how to manage this kind of situation. So DWI flare mismatch means that the stroke is very early. So you have a small core with a larger penumbra, and that's useful for wake-up stroke decisions, okay? And MRI is good for all this, but it's slow and it's expensive. That's why it's not the first line. So if the non-contrast head CT shows no hemorrhage and the patient is within the treatment window and has a disabling deficit and has no contraindications, you don't delay reperfusion treatment waiting for these other tests. Early presenters benefit from speed more than additional imaging. So this is how you avoid harming the patient by over-ordering tests and waiting too long. The mechanism and the time window should be the driving factors in this, not the desire for a perfect diagnostic picture. So non-contrast head CT, rule out the bleed. CT angio, find the clot. CT perfusion is to decide whether reperfusion is still worthwhile, and then the MRI when the picture doesn't make sense. Each tool is answering a different question. The faster you match it, the better the outcome. Okay, so now that we've covered acute reperfusion, we're going to talk about what keeps the patient alive now in the acute phase. So this is about supporting the parts of the brain that survived and preventing another stroke. So we're going to break this into three buckets now, okay? So the first is going to be acute management. This is hours to days. Blood pressure, this is where they allow permissive hypertension. In acute ischemic stroke with no TPA, they're going to allow the pressure up to 220 over 110 because the brain is relying on high pressure to perfuse the penumbra through the collateral vessels. After TPA, that threshold has to stay under 180 over 105. High pressure increases the risk of a hemorrhagic conversion. So that's what we're trying to prevent. Your glucose goal is anywhere from 140 to 180. Why? Because hyperglycemia worsens the ischemic cascade and can increase infarct size. So avoid both extremes. And also, tight insulin control is harmful because hypoglycemia re-triggers a stress response again. So you need good glycemic control. Fever management is also essential because anything over 38 degrees Celsius is going to fuel excitotoxicity, and that's going to worsen neuronal injury. So that's why we treat fevers aggressively in a stroke patient. And then DVT prophylaxis and early mobilization, obviously, because stroke patients will clot easily because they're in this pro-inflammatory state and they may have increased viscosity of their blood. So you get them moving early, if safe, and give DVT prophylaxis. The next bucket is the antithrombotics bucket. And this is where you match the drug to the stroke mechanism. So a non-cardioembolic stroke, these are the ones that are getting aspirin. The dual antiplatelet therapy, those are the short-term dual antiplatelets. So those are aspirin and clopidogrel. It's reasonable for minor strokes or TIAs. Typically, they do a 21 to 90-day course depending on the protocol. If they do have a cardiometabolic stroke, meaning they had AFib, these patients need anticoagulation, not antiplatelets. So timing for this depends on how big it is. If it's small, you can start in 3 to 5 days. If it's moderate, you start a little longer, 7 to 10 days. Large strokes wait longer because they are at higher risk for a hemorrhagic conversion. The other thing is these are the ones that go on the high intensity statins because their new LDL goal is going to be less than 70. Statins are said to stabilize the plaque and reduce recurrence. The third bucket of treatment is long-term prevention. This is tertiary prevention. Your goal for blood pressure for them is going to be less than 130 over 80. Why? Because hypertension is the number one modifiable risk factor. Carotid artery stenosis, greater than 70%. They may need a carotid endarterectomy. If they have a patent foramen ovale, that's why they do echoes as part of the stroke investigation. In younger patients less than 60, they may consider closing it. Obviously, lifestyle, smoking, and the like, sleep apnea needs to be dealt with. The bottom line here is basically once you determined what caused the stroke, that's where your treatments are aimed. The first week after a stroke is the most critical time period for preventing the next one. All right, let's do this clinical case here. So let's walk through this here. You're in the ED. This is exactly the type of patient who you may have to move fast and think clearly along the way. So what do we have here? Look at this case study in front of you. What jumps out in front of you? This is a 55-year-old right-handed male with sudden onset left facial droop, left hemiplegia, 0 of 5, meaning flaccid and no movement, global aphasia. The NIH stroke scale is 18, meaning this is a big stroke, and his last known well was 80 minutes ago. So this puts him comfortably inside the TPA window, which is less than 4.5 hours, and the standard thrombectomy window, which is less than 6 hours. So the blood pressure is 178 over 102, which is permissive for now. His glucose is 142. We like that in the safe range. He's afebrile and he's oxygenating well. So what is your first imaging? Non-contrast head CT shows no hemorrhage and subtle early ischemic changes in the right middle cerebral artery territory. So he goes for CTA, and what you see is a right ICA terminus and an M1 occlusion. This is a large vessel occlusion. The labs are appropriate, INRs 1.1, platelets 215. Everything here is lining up for both IV thrombolysis and mechanical thrombectomy. So the first question is IV TPA eligibility. So for thrombolysis, you need to have three things. Within 4.5 hours, yes. Disabling deficit, yes. No contraindications, platelets are fine, INR fine, blood pressure less than 185 and treatable if needed, no hemorrhage on CT. Perfect candidate for TPA. So should he get it immediately? Door to needle, less than 30 minutes. Clinical question 2 is blood pressure management before and after reperfusion. So before TPA, you need to reduce it to less than 185 over 110. He's already below that. After TPA, we need to keep it less than 180 over 105 for 24 hours to prevent hemorrhage and hemorrhagic transformation. If no TPA was given, then you would allow permissive hypertension. So this depends on where you're practicing, basically, what you can do and how you're going to manage them as best you can, given the constraints. So if you wind up in rural medicine, you might have to go the later route. Clinical question 3 here, thrombectomy criteria and timing. He has a right ICA M1 occlusion. That's the classic large vessel occlusion territory. And the criteria for thrombectomy, proximal large vessel occlusion, ICA M1. Disabling deficit, favorable imaging, yes. So within 6 hours, up to 24 hours, with a favorable penumbra, the patient easily also qualifies for that. The door to groin puncture target is less than 60 minutes here. So you can administer TPA, mobilize the interventional team, no delays, move this along. The fourth question to consider here is this post-reperfusion monitoring and management. So after reperfusion, you need to perform neurochecks every 15 minutes, monitor for hemorrhagic transformation, keep that blood pressure controlled, and avoid any unnecessary antiplatelets post 24 hours. And then you're going to re-image them again in 24 hours and start that high intensity statin. And then eventually early rehab, swallow evaluation, and discharge planning. So this case is like the perfect storm of pathophysiology that your workflow can really help. So a devastating MCA stroke, a clear large vessel occlusion, a clean CT, a narrow time window. This is exactly the sort of rapid response that you need to contend with without panic and save the penumbra. All right, why don't we take a little pause here? I'm going to pause the recording. All right, so now we're going to shift gears into seizures and epilepsy. And this is a topic where classification, mechanism, and treatment have to line up, or you're going to miss the diagnosis and give the wrong drug when that time comes. Now, this section is developing an eye for seizures, not just spotting them when they happen, but the goal here is that you understand why they happen, where they start, how they spread, and what it means for management. So seizures come from abnormal hypersynchronous neuronal firing. And the root cause is going to fall into a few major buckets. You can either have a structural lesion, a metabolic trigger, or some sort of genetic epilepsy situation. So structural lesions would be things like tumors or strokes or cortical dysplasia, trauma. That would be a structural lesion. A metabolic trigger would be something like hypoglycemia, hyponatremia, alcohol withdrawal, etc. Genetic epilepsies, these are specific syndromes with characteristic cymology. Now, cymology is the EEG pattern. So before you even think about a medication, you need to classify the seizure based on the observable pattern, the EEG pattern. And the question you're going to ask is this focal or generalized? Is it motor or non-motor? Is it with impaired awareness or without? Every detail of that presentation is going to point you to the origin of the electrical disturbance. So the subtitle on this slide matters. What you want to do is classify accurately so that you can appropriately investigate and then match the therapy to the mechanism. Because if you misclassify a focal seizure as generalized, you're going to probably reach for the valproate when the better option might be carbamazepine. So if you miss a provoked seizure, you might start lifelong therapy unnecessarily. And these drugs are not benign and they do have downstream effects. So if you don't recognize a red flag like status epilepticus or focal seizure pointing to a mass, you're going to miss the diagnosis that has nothing to do with epilepsy at all. So for the next few minutes, we're going to anchor everything into this flow of mechanism, cymology, workup, and treatment. And you're going to see how much simpler a seizure evaluation can become. All right, so let's zoom into the neuron and talk about what actually creates a seizure. So if you understand these four mechanisms, almost every anti-seizure drug is going to make sense. So the neuronal hyperexcitability, that's a seizure that begins with proximal depolarization. Basically, a neuron that refuses to shut up. This thing, instead of firing normal, controlled action potential, it goes into sustained high frequency firing. That's the spark. So anything that makes a neuron more excitable, like electrolyte imbalance, genetic mutations, inflammation, metabolic derangement, that can set the stage. The second is excitation inhibition imbalance. Now, this is the core concept of epilepsy. Basically, too much glutamate, which is the excitatory neurotransmitter, and or too little GABA, which is the inhibitory neurotransmitter. If you're in the psych program, these will become your friends when we talk about psychopharm next term. Glutamate acts through the NMDA receptor, and which you will see labeled on this slide here with these receptors. They're overactive. And what's happening is the neuron is firing aggressively, and when the GABAergic inhibition is reduced, there's nothing to stop the chain reaction. So this imbalance is why drugs like benzodiazepines, which increase GABA activity, they work essentially because you're just putting more inhibitory neurotransmitter in the system. The ion channel dysfunction is the third bucket. This is where what they call channelopathies come in. Channelopathies are things that alter sodium, potassium, and calcium channels. So if the sodium channel stays open too long, neurons will fire too easily. If the potassium channels don't repolarize the membrane, firing becomes unstable. And if calcium channels misfire, then neurotransmitter release becomes dysregulated. So this explains why things like sodium channel blockers like carbamazepine, phenytoin, lamotrigine are so effective for focal seizures. Another bucket is this hypersynchronation. So one hyperexcitable neuron is not a seizure. A seizure happens when that hyperactivity recruits surrounding neurons, creating a synchronized firing across a network. So what you get is propagation that occurs through what's called synaptic spread. That's glutamate mediated. Why glutamate? Because that's excitatory. And changes in the extracellular ionic environment, this is what gives the seizure their characteristic rhythmic pattern. So what? So when you know the mechanism, you can choose the right drug. So if it's a sodium channel dysfunction, carbamazepine, lamotrigine, phenytoin. If it's excessive glutamate, that's the one getting the NMDA modulators. If it's GABA deficiency, that's benzodiazepine, barbiturates, valproic. And then if it's mixed, that's where you wind up on broad spectrum agents like Levictram, Keppra, or valproic acid. So your medication choice is not random, it should be mechanism based. That's not to say you don't sometimes start with something broader and then on further investigation you may tailor it down to something a little more specific. So a seizure is basically this perfect storm of hyperexcitability, lost inhibition, dysfunctional channels, and network recruitment. So here is a seizure classification table for you. So this is kind of like bedside, equivalent to the stroke chart I showed you. This is like a dictionary of how to read seizures based on what you see. So if you get the symptomology right, the workup and the medication will hopefully follow. Now, these start on a specific cortical region, these focal onset seizures. And the features depend entirely on where the region lives. So focal aware, what we call simple partial, awareness is preserved. Motor signs, like in these Jacksonian march, spreading clonic movements, or non-motor signs, they will cause sensory changes like deja vu or autonomic changes or emotional shifts. There's an EEG pattern here, which is rhythmic discharges in one region. They may be subtle or even normal if the focus is deep. So this is where that concept of aura lives in these focal seizures. Okay, the aura is the earliest focal symptom. Now, the other group here is to look at focal impaired awareness. And focal impaired awareness, this is a complex partial seizure. And the key word here is altered consciousness, staring, oral automatisms, the mouth starts to twitch, fumbling. Often this is temporal lobe in origin. And the post-ictal confusion is normal and common here. And the EEG is going to show you what they call rhythmic theta and alpha waves in the temporal regions. And you'll get regional spread and some post-ictal slowing if you connect them to the EEG, be it the continuous monitoring one. The next seizure to note here is this generalized onset seizure. These start with synchronous bilateral cortical activation. There's no aura, there's no warning, there's no focal onset. And the description is tonic-clonic, that is stiffening with rhythmic jerking, or myoclonic, that is quick jerks. Usually they're symmetric. Atonic means the sudden loss of tone. This would be like a drop attack, like what we see in narcolepsy, cataplexy. Tonic would be the sustained muscle contraction, and the EEG will show spikes or polyspike wave patterns, diffuse or bilateral, in the general onset seizures. The next one is this generalized non-motor absence seizure. This is the classic pediatric type of seizure. It typically lasts about 5 to 10 seconds. They have a lapse. They look like they kind of just intermittently space out, or they kind of pop into screensaver mode, it seems. And then they just immediately resume their activity afterwards. These are atypical, longer, slower onset, offset. That's a typical presentation of it. The typical is typically just a 5 second reset break and then back to it. So those are two different presentations of the generalized non-motor. They will have myoclonic absence, maybe very small myoclonic jerks with the lapse, and the EEG is typically a 3 hertz generalized spike wave. Atypical is less than 2.5 hertz. You're not going to read the hertz per se. You will get an EEG report that will have this on there, kind of like the description before they give you the final impressions. So this is one of the most specific EEG findings that you will have in this generalized non-motor absence seizures. There's another one here that's unknown onset seizure. These are seizures where onset was not witnessed, often discovered when the patient presents with a tonic-clonic episode. EEG patterns vary here because we don't know when it starts and ends. The diagnosis becomes clearer with repeat EKGs. So just the major take-home message in all these seizures is if a patient reports an aura, the seizure is focal onset, even if it later becomes generalized. Why this matters is because focal to bilateral tonic-clonic seizures need focal onset medication, like carbamazepine or oxycarbazepine. Primary generalized seizures respond better to broad-spectrum agents like valproic acid and keppra-levictrum. So classifying these first 5 seconds of a seizure is more important than classifying the last 5 seconds of the last 5 minutes of the seizure, because that's going to tell you the onset is really the driving factor as to what kind of seizure this really is. So use what you see to localize the onset, and then use onset to select the right diagnostic pathway. So now we're going to walk through this algorithm, but this time through the lens of the pathophysiology. So a seizure is a symptom of cortical hyperexcitability, but what causes that excitability is vastly different. So the workup is essentially a search for what caused it to act this way. So the first initial evaluation in a seizure is identifying the physiologic origin. That's the most important diagnostic tool. And that is the history, because this will tell you where in the cortex the event likely started and why it may have happened. So seismology is the onset, progression, and recovery, and this tells you the cortical territory involved. So for example, if they had rising epigastric sensation, that would make you think mesial temporal lobe involvement. The amygdala and the hippocampus are firing abnormally. If there's somatosensory tingling, that might indicate parietal cortex. So primary sensory strip is what's misfiring there. If they have a forced head deviation, like the frontal eye fields might be at play. If they have automatisms or staring, that may indicate temporal lobe. So this is supposed to help you differentiate focal firing, structural, channelopathy, autoimmune, from generalized firing, thalamocortical network instability. Eyewitness accounts are very helpful here. These will tell you the phases. There's pre-ictal aura. That means focal cortical firing before synchronization. Ictal behaviors, that's the propagation pattern in the midst of the seizure. And then the post-ictal confusion, that's the widespread neuronal exhaustion. They look like they need a nap. So a true seizure shows a post-ictal slowing because the neurons have to enter a refractory metabolic period. Okay. So also we need to pay attention to things like prodrome, aura, and triggers. These will give you mechanistic clues. So what are some triggers? Well, sleep deprivation, because there's reduced cortical inhibition and GABAergic fatigue. There may be alcohol withdrawal, NMDA upregulation, and positive loss of GABA tone. There could be missed medications, and that would be something like a sudden loss of a sodium channel stabilizer. So what we do is, because we're trying to capture things, we might do like a video recording to allow you to directly observe lateralizing signs, automatisms, motor spread, post-ictal transitions. That's what we're looking for when you order the video EEG. And these features map onto cortical networks and propagation pathways. The first seizure workup, each test is going to target a specific pathophysiologic category. So MRI is with an epilepsy protocol is the first one of the first tests you'll do when you're working somebody up for seizure. And what is this epilepsy protocol? Well, what you're looking for, radiologists will have this. You can just tag it for that, but you should know what they're looking for. They're looking for things like cortical dysplasia, which would be like malformed neurons, which are prone to synchronized firing. Or tumors. The tumor may be so big that it's causing a mass effect, irritating the cortex. Or you might see some scarring and sclerosis, especially in mesial temporal sclerosis. Maybe they've had a stroke, a new stroke, or an old infarct. There may be cavernous malformations or vascular lesions. These structures distort the local circuitry, lowering the seizure threshold, creating a focal onset zone. So MRI is far more sensitive than CAT scan for subtle hippocampal atrophy. Cortical malformations, gliosis, encephalitis, all of these are related changes that could show up on an MRI. And that's the thing that's going to distinguish, quote unquote, structural epilepsy, right, from a provoked seizure. So provoked seizure and structural epilepsy are not the same thing, because the theory is that if you deal with the provocation, the metabolic cause, this person doesn't have epilepsy and doesn't need lifelong therapy. They just need the trigger mitigated, and then you can give them a quality of life. Also, they can get back to driving and leading a normal life. EEG is routine. There are three kinds. You can do routine EEG, it's a random 30-minute. You can do a sleep-deprived EEG, where you deprive of the sleep and see if that triggers it, or prolonged EEG over the course of several days. What you're trying to find is abnormal electrical firing patterns. So intraictal epileptiform discharges, that's what they're called, spikes and sharp waves, that's the hallmark of cortical hyperexcitability. Now, focal slowing, that's a tell of possibly a structural lesion. If you think about, there's a structure obstructing the conduction, so you might see focal slowing rather. Generalized spike wave, 3 hertz, that's a thalamico-cortical channelopathy and absence seizures. You might see a polyspike wave on an EEG. That's a myoclonic epilepsy, and that will point you in the direction of a sodium-potassium channel dysfunction. Post-ictal slowing, that's a physiologic seizure recovery, and sleep deprivation unmasks cortical instability because it reduces the GABAergic tone, enhances the glutamatergic drive, and promotes hypersynchronous firing. That's why sleep-deprived EEG is considered more sensitive. Basically, think of EEG as the electrophysiology of the brain, right? And you're trying to trigger the person to have their seizure in a controlled setting where you can capture it and say, aha, that's what you have, let me treat you. Otherwise, we're all going on history, and if we never could provoke it again, we're always living in this ambiguous state of not knowing. Some lab testing to pay attention to in a diagnostic workup for seizures. Electrolytes, obviously. Hyponatremia can cause neuronal swelling and membrane instability and then lead to seizures. Incidentally, you can cause hyponatremia or relative hyponatremia if you bring down somebody's sodium too fast. So that's why it's important to note that. Hypernatremia, on the other hand, also can cause seizures. They can cause neuronal shrinking and some cortical irritation. Hypocalcemia, that lowers the threshold for NMDA activation, leading to excitotoxic risk. Hypomagnesemia that releases NMDA inhibition. This is popular in the OB postpartum world. And so they do give infusions of magnesium to control seizures for this reason, because hypomagnesemia causes excessive glutamate-driven firing. So these cause global cortical irritability, leading to generalized seizures, not epilepsy. Okay. Another trigger, the reason we do a glucose in this workup is because hypo and hyperglycemia can cause seizure activity. Hypo because of ATP failure and it can't maintain the membrane potential and that leads to seizure. Hyperglycemia, that puts you in a hyperosmolar state, leading to neural dehydration, and that can lead to excitability. And these mimic seizures because the brain can't maintain normal ionic gradients. So that's why each of these tests matters. I spelled them out for you because you order routine lab CMP, calcinide phos, and a CBC on everybody, and then you're like, well, what am I actually looking for here? So that's why I'm taking the time to tell you what you're actually looking for here. When you look at the renal and liver function panel in uremia, the toxin accumulation can alter the neurotransmitter. That can cause a seizure. In liver failure, if they have hyperammonemia, that can lead to astrocyte swelling and disrupt the GABA glutamate balance, and that can cause a seizure. So both produce metabolic encephalopathy with seizures. Now, what about the toxicology? Well, alcohol withdrawal, massive NMDA upregulation plus GABA collapse, and that can cause a seizure. If they're on cocaine and amphetamines, you get a catecholamine surge, cortical activation, overactivation, and that can cause a seizure. You can have synthetic cannabinoids and bath salts. That's unpredictable excitatory inhibitory disruption, and that can provoke a seizure. All we're talking about so far is what is provoking seizures, not epilepsy. Don't use epilepsy and seizure interchangeably. Now, what about the ECG pattern here? So cardiac syncope can mimic a seizure, right? Arrhythmias can cause cerebral hypoperfusion, leading to myoclonic jerks, and that can be mistaken for a seizure. Nope, the tell is that there's no post-ictal state and there's no cortical firing. It's just transient anoxia. So this is why ECG is essential when the event might be cardiogenic. Now, when the picture is suggesting a deeper cause, right? So lumbar puncture, that helps diagnose because things like HSV encephalitis can lead to temporal lobe inflammation, and you might get focal seizure findings that way. How about bacterial meningitis? That will trigger a cytokine storm, and that can lead to cortical irritation. Or what about autoimmune meningoencephalitis? Well, fever plus altered mental status plus new seizure, lumbar puncture. Okay. So just kind of keep that criteria in mind. Fever, altered mental status, and new seizure, lumbar puncture. Now, there are some autoimmune conditions and panels that we can do that can cause this antibody-mediated receptor dysfunction. So, for example, anti-NMDA receptor encephalitis. I just put an article on that out last month. Feel free to pull it up in the Journal for Nurse Practitioners. It's a clinical summary of anti-NMDA receptor encephalitis. Antibodies attack the NMDA receptor, and that can lead to severe psychiatric symptoms and seizure. So the tell, by the way, is if they're having psychiatric symptoms between the seizures, you're supposed to go look for this anti-NMDA receptor encephalitis. There's also a video on YouTube that I put up about anti-NMDA. Feel free to check that out in your downtime because you love patho so much. Okay, so there are some limbic encephalopathies that can happen with these paraneoplastic findings. So there are some lab tests here that you can see. And basically what we're looking for is something alongside causing antibodies that is making the brain hyper-excitable to cause what we are calling seizure-like activity. And so some of the tells would be if somebody's having acute personality changes, cognitive decline, a movement abnormality, or the seizures are treatment resistant, So if something does not behave the way you expect it to look, or if something doesn't fail the way you expect it to fail, that is an atypical presentation. That should prompt you to go looking for zebras, essentially. So genetic testing is something you can look at and refer for because there could be some inherited channelopathies or cortical malformations. So things that they would look for would be like sodium channel mutations, potassium channel mutations, chromosomal disorders with malformations. That can explain epilepsy, and that would start in childhood or adolescence. Video EEG monitoring. This is intended to show essentially ictal discharges, post-ictal slowing, physiologic propagation patterns, no epileptiform activity, normal background, movements inconsistent with cortical spread. These tests are designed to prevent misdiagnosis and the inappropriate use of anti-epileptic drugs. Most epilepsy misdiagnosis happens because somebody skipped the history or failed to chase the mechanism. So when they come to you, even though they've been worked up, whenever you're seeing a patient for the first time, pretend you're seeing them for the first time and ask every question. Don't just assume the medical record is accurate, and don't just assume all the doctors have talked to each other, because if you've been around long enough, you know they haven't, and they don't even read each other's notes. So you be the difference. It's low tech, but it's high yield. Read the notes and take a very detailed history, because when you understand what each test is looking for and why, you're going to really help the patient along. All right, so from diagnosis to treatment, what we're dealing with is this electrical problem. So each medication has a means of stabilizing. So when do you initiate therapy? Well, therapy is initiated and it's driven by recurrence risk is really what we're trying to do. Because what are we treating? We're trying to prevent the next one from happening. So after a first unprovoked seizure, we treat when the biology tells you that the brain is at high risk for it happening again. So what would tell you that it's at high risk for it happening again? Well, that would be an abnormal EEG with eleptiform discharges. Okay, so these are spontaneous hypersynchronous bursts and the electrical fingerprint of a cortex primed for seizure. If these are present, the brain's already demonstrating hyperexcitability at baseline. So recurrence risk is about double. Also, if they have structural lesions or prior brain injury, like with scar tissue or tumor or stroke or cortical dysplasia, all of those things distort the local circuits and decrease inhibitory and interneuron function. So these create a permanent seizure focus, not a transient irritant. That's the person that's going to be on anti-epileptic drugs. The other thing you're curious about is there a history of unprovoked seizures? Like after a second unprovoked seizure, the recurrence probability is about 60%. So biologically, that means the brain has transitioned to epilepsy from a chronic state of recurrent hyper-excitability. The other thing is patient preference, meaning driving and high-risk occupations. Therapy is also a safety decision. So if you're a long-distance truck driver or scuba diver or something where lives are in your hands, seizures involving loss of awareness carry significant injury risk. So an error on the side of caution might be to go on medication therapy because we don't exactly know the real risk here. So typically you want to start simple, monotherapy versus polytherapy. Most patients are controlled with a single drug because most epilepsy syndromes are typically from one dominant mechanism. So monotherapy is effective in about 60 to 70% of patients, and then there's minimal side effects, and it allows for a clear interpretation of response and targets the primary dysfunction. Most focal epilepsies respond to sodium channel blockers. Generalized epilepsies respond to broad spectrum agents. So you might try 2 to 3 anti-epileptic drugs sequentially, and different drugs will target different pathways. So you might have sodium currents, GABA-tone, synaptic vesicle release, calcium channels, glutamate transmission, and then sequential trials, meaning you put them on a med and you see if they had a seizure. That's what helps you identify mechanism, giving them the best chance of seizure control. So there is an element of trial and error here, and some people are not willing to risk the trial and error because the fallout can be great. And so that's how people wind up on these bigger guns that kind of suppress across the board. So polytherapy is used when multiple mechanisms are at play, like a patient has a mixed myoclonic plus tonic-clonic seizure. They may need GABA enhancer plus a sodium channel agent. You want to avoid drugs with overlapping toxicities or redundant mechanisms because they add little value. Now, mechanism and target selection here, this is where it's a little bit of an art. Sodium channel blockers, examples like carbamazepine, lamotrigine, phenytoin, these things stabilize inactive sodium channels and suppress the rapid repetitive firing. These are best for focal seizures, generalized tonic-clonic seizures, and they're the disorders where neurons are firing repetitively due to unstable membrane potentials. The other class is GABA enhancers, and those are things like valproic acid, benzodiazepine, phenobarbital. They increase inhibitory tone through the GABA A receptor potentiation. They counteract that excitation inhibition imbalance. So these are best for things like generalized epilepsies, myoclonic seizures. These conditions involve impaired inhibitory interneuron function or excessive thalamocortical excitability. The calcium channel modulators, these are the things that are triggering absence seizures. They suppress T-type calcium channels in the thalamic neuron. Why they work is because absence epilepsy is a thalamocortical rhythm disorder. So these channels generate that 3 hertz spike wave discharge, and that blocks them, interrupting that pathological oscillation that may be reported. There's another drug here, the SV2A modulators. This is Levictram and Brivictram. These modify the synaptic vesicle release. They dampen excitatory neurotransmission. They're considered broad spectrum, and they're good because they have minimal drug-drug interactions, and you can draw levels to see if they're therapeutic and if they're taking them, because that's very helpful to know. So that's useful when the seizure phenotype is mixed or unclear. You also will see them in areas where the patient can't get into neurology or an EEG for some reason because they're rural enough or they don't want to drive the 2 hours. You might see this as kind of a let's cover all our bases type approach. And the drugs have gotten safer and less adverse effects over time. There are some multiple mechanism drugs. Those are valproic acid and topiramate. They act on the sodium channels, GABAergic tone, glutamate pathways, carbonic anhydrase. And these are powerful broad spectrum agents for complex seizures. Valproic has been around a long time. You can therapeutically drug monitor it. You got to follow liver enzymes and platelets and supplement the folic acid, and you want to avoid it in women of childbearing age. It also acts as a mood stabilizer. It's good if the person won't take anything oral because it's also injectable. You can load them. So valproic has hung around for a long time because it's very versatile. Now, there are some individual factors here. Valproic acid is one of the best broad spectrum options, but its teratogenic risk makes this inappropriate for most women of childbearing age. And basically, what we're trying to do here is match the drug mechanism to the seizure mechanism. So early onset or refractory epilepsy should prompt genetic testing. So if you have children with new onset seizures, that's who's going to get genetic testing because it'll often reveal the channel or receptor defect, and you can really tailor the therapy that way. All right, let's walk through this case on seizures here. Okay, so what we're going to look at here, you've got this 28-year-old woman who presents to the ED after a witnessed generalized tonic-clonic seizure. So first, her story is almost the textbook example of the temporal lobe epilepsy with secondary generalization. So look at her sequence. She reports to you a deja vu aura and an epigastric rising sensation. That is classic mesial temporal onset. The amygdala, the hippocampus, and the insular connections are producing these visceral warning signs, and then she becomes unresponsive and stares for 30 seconds. That's impaired awareness. The seizure has now spread to networks controlling consciousness. Next comes her bilateral arm and leg stiffening, followed by a rhythmic jerking. This is the tonic phase. Clonic phase pattern you'll see when focal seizure activity propagates through both hemispheres via the corpus callosum and the brainstem and motor circuits. So finally, what you get is a long postictal period. That's the brain's metabolic recovery after the widespread neuronal depolarization. So before we even look at imaging, the story is already telling you this is a focal onset with impaired awareness, bilateral tonic-clonic. That's how you describe this. So what each finding means. So if you do the MRI, you'll see the left mesial temporal sclerosis. And this is one of the most common structural substrates for temporal lobe epilepsy. So what's happening pathophysiologically then? Well, neuronal loss at CA1 and CA3, gliosis, reorganization of the excitatory circuits, and a loss of inhibitory neurons. All of this lowers her seizure threshold and creates that stable epileptogenic focus. The EEG has a left temporal intraictal sharp wave, and that interictal sharp wave at the electrical equivalent of the MRI finding, essentially. So they're reflecting this hypersynchronous burst coming from that scarred hippocampus. So in other words, the MRI is showing you a structural lesion. The EEG shows you the functional instability that's associated with it. So this helps rule out metabolic causes, confirming that this epilepsy is not a provoked seizure. Okay, ILAE is a classification system that you can look up, but in general, it's another way that we classify seizures. But what you're seeing here is this focal onset proven by the aura and EEG focus with impaired awareness. That's the staring episode involving bilateral tonic-clonic, which is the last stage. So focal onset, impaired awareness, bilateral tonic-clonic seizure. The distinction matters because the treatment follows. So the medication that you would start, because she has epilepsy, and the reason you're starting it is because this is not just like an episodic seizure disorder. She indeed has a structural brain defect, which makes her epileptic. She has three major high-risk features. She's got the structural lesion, the abnormal EEG, and the clear focal cymology over months. She has spells of déjà vu, which indicates she's had several unrecognized prior seizures. And each of these doubles or triples her recurrence risk. So together, she's going to have more than a 70% chance of recurrent seizure. So she meets the criteria for diagnosing epilepsy, not first seizure. And so that's the patient that does get treated with medication. So the best anti-seizure medicine for this patient for focal epilepsy to suppress that repetitive firing from the scarred temporal tissue is going to be something like a sodium channel blocker, carbamazepine, oxycarbamazepine, or lamotrigine. Now, the complications of lamotrigine are alive and well here as well, the Stephen Johnson sequelae, so you kind of have to pick your poison properly. But the goal is to prevent rapid, repetitive neuronal depolarization, which is a core mechanism in the mesotemporal epilepsy. There are options for broad spectrum modulators. These reduce excitatory neurotransmitters and release. And so they're a good choice for women in childbearing age, which she is. She's 28 years old because they avoid the teratogenic risk. And then the other thing is you got to talk about counseling her for safety, driving, and lifestyle adherence. This is super important. So, for example, New York requires a seizure-free interval of 12 months, depending on circumstances. So she must stop driving immediately. Medication adherence, missing doses is one of the most common triggers for breakthrough seizures, especially in temporal lobe. And you want to avoid sleep deprivation, because that lowers the seizure threshold. You also want to avoid excessive alcohol because withdrawal provokes the seizure threshold. Maintaining hydration, adequate meals, stress management, safety preoccupations, no swimming alone, no climbing heights, consider showering instead of baths, all of the things that may trigger vasovagal. Um, and the patterns to watch are the deja vu spells, because they may have been previously unrecognized seizures, so that recurrence should prompt, we need to follow up and retreat. So the aura tells you the seizure origin, the MRI tells you the structural cause, the EEG tells you the functional instability, the seismology tells you the network propagation, and the treatment choice targets the electrical mechanism. So some questions I may ask you is, what test would you do this for? That's probably something I would ask you, because I'm not going to ask you super detailed neurology referral questions, but I want you to do the workup on the way to neurology, because that's likely the level that you'll be practicing at. Now, if you wind up in neurology, then this is all good. You're primed and ready to go. All right, let's move on to multiple sclerosis. Stand and stretch, yawn, get a drink, do what you got to do, but we're going to go right on to multiple sclerosis. Pump your ankles. Hopefully no one's getting a DVT out there. Here we go. All right. So multiple sclerosis, this is a disease that rewards you if you understand the underlying biology. So if you know the mechanism, then you immediately will understand the symptoms, the diagnostic workup, and then the treatment strategy. So what is MS? Well, MS is not just autoimmune demyelination. It's actually a two-phase disease with overlapping processes. So phase one is the inflammatory demyelination. This is the immune system attacking myelin in the CNS. And it's mediated mostly by T cells and B cells and antibodies, the same stuff that's been mediating the inflammatory cascade from the first lesson up until now. And so what's the result here? Well, when you attack the myelin, you cause this conduction block, which slows nerve transmission. And that's a transient neurological deficit depending on the lesion location. So this is why patients present with sudden episodes of things like optic neuritis, sensory loss, limb weakness, ataxia, diplopia, all because the myelin is stripped off in patches. That's phase one. Phase two is the neurodegeneration phase. This happens over time. The demyelinated axon becomes vulnerable, and then they start degenerating. And that leads to things like brain atrophy, cognitive decline, progressive disability. This phase is less inflammatory and more degenerative, which is why immunotherapy helps in late stage MS. So lesion location will dictate the symptoms. So in MS, the symptom depends entirely on where inflammation occurs. So optic nerve, they may have painful vision loss. If it's brainstem, they may have diplopia and vertigo. If it's spinal cord, sensory level weakness and bladder dysfunction. If it's cerebellum, gait instability and tremor. So every relapse tells you exactly which neural pathway is being disrupted. So the clinical pattern is the dissemination, which is the key concept. And there are two kinds of dissemination. There is dissemination in space, that is lesions in different CNS regions, optic nerve, spinal cord, cerebellum, or there is dissemination in time, different episodes occurring months or years apart. Our diagnostic workup is essentially trying to prove both of these. Why this matters for treatment is because once you understand the mechanism and the treatment becomes kind of intuitive. Relapse reflects active inflammation. You treat that with high-dose steroids, and if it's severe, you can escalate to plasmapheresis. Long-term disability reflects neurodegeneration, and you prevent this by starting them on disease-modifying therapy early. Immunotherapy selection will depend on disease activity, MRI burden, patient characteristics, and risk tolerance. The big message here is you're treating the immune system to protect the nervous system. So some of the diagnostic tests we use in MS are things like clinical signs, MRI, CSF. Those help us identify the red flags, and then we try to understand immunotherapy as mechanism-targeted treatment, which drug fits which disease pattern, and then we're going to manage the relapses and progression intelligently, hopefully, knowing when to escalate therapy, when to switch class, how to monitor safely. Everything we do is going to ultimately revolve around identify the inflammation early so we can stop it before it becomes neurodegeneration. All right, so here is the MS pathophysiology pathway from inflammation to neurodegeneration. So here we go. So autoimmune trigger fires, and this is the first link in the chain. So something in the environment hits a genetically primed immune system, and that triggers this activation of the T cells that recognizes myelin and gets activated in the periphery. So you don't need the exact trigger at the bedside. You just need to remember that MS starts outside the brain with a miseducated T cell. And then we go to blood-brain barrier breakdown, and those activated T cells upregulate adhesion molecules and inflammatory cytokines like TNF alpha and IFN gamma. And this lets them stick to cross the blood-brain barrier. Now, once inside the CNS, they're starting an inflammatory party that the brain never asked for, and you have now the inflammatory cascade. So in the CNS, T cells recruit B cells and macrophages. Stop me if you've heard this before. And they wake up the microglia and activate the complement cascade. And now you've got this full immune swarm, myelinated axons releasing reactive oxygenate and protease and cytokines. And then the fourth step is this demyelination process where the attack focuses on myelin-specific antibodies which bind up the sheath. And then complement punches hole in it, and the macrophages are literally eating the myelin. And the oligodendrocytes undergo apoptosis, which is programmed cell death. And clinically, this is the relapse conduction block, whatever pathway is inflamed, optic nerve, spinal cord, or brainstem. Now, the fifth thing to pay attention to is this axonal injury and neurodegeneration pattern. So even after the inflammation cools down, the damage isn't over. There's more. Chronically demyelinated axons, they burn more energy to conduct impulses and accumulate calcium and mitochondrial injury, and eventually they degenerate. So then you develop this remyelination, except it's often incomplete. So with each relapse, you stack a bit more irreversible axonal loss. So that's how a relapsing disease suddenly becomes a progressive one. So what does this mean clinically? Well, the whole cascade explains why we have two therapeutic goals in MS. You have the anti-inflammatory and the immunomodulating drugs, and these are designed to block the early steps of the T and B cell activity, crossing the blood-brain barrier, trafficking the inflammatory storm into the brain that they didn't ask for any of this. The other goal is this neuroprotection and to slow the progress strategies to preserve the axons once damage has been established. So every MS drug you're going to learn going forward, you look up the mechanism of action, you're going to notice it's trying to stop one of these pathways here. So that's the pathophysiology. Well, how does it manifest? What will your patient show you? Well, MS doesn't produce random symptoms. It produces focal deficits that map perfectly to the CNS region where the inflammation hits. So as we go through these, think lesion location and clinical behavior. All right, up first, let's talk about optic neuritis. So, optic neuritis is one of the most classic presentations. Why? Well, the optic nerve is myelinated by oligodendrocytes. So, that's the prime immunotarget in multiple sclerosis. Now, when inflammation hits the optic nerve, you get monoocular vision loss because the vision is anterior to the optic chiasm. So then you get this central scotoma. That's the papillomacular bundle in especially myelin dense and easily injured. So then you get pain with eye movements because the inflamed optic nerve sheath tugs with extraocular muscle movement. And then you get this relative afferent pupillary defect called RAPD, relative afferent pupillary defect. The injured optic nerve transmits less afferent light signals. Well, the important clinical point here is that 90% will recover their vision because the inflammation resolves and the conduction improves, even if remyelination is incomplete. So that provides a little hope to your panicked patient. Another manifestation is transverse myelitis. Now, transverse myelitis is an MS spinal cord lesion. And a lesion here produces symptoms that stack longitudinally. So you'll get at the sensory level a band-like level because the spinal tracts are somatotopically organized. You'll also see something called Lermit's sign. This is electrical shock sensation with neck flexion. And so this happens when demyelinated dorsal columns misfire under mechanical stretch. Another dysfunction in the transverse myelitis is this bladder dysfunction because the descending autonomic pathways run in the lateral spinal cord. This pattern, motor plus sensory plus autonomic changes below a specific level, points directly to a spinal cord lesion. There's another manifestation, which is brainstem and cerebellar lesions. Now, these give you extremely localizable findings. You will see here internuclear ophthalmoplegia, INO, intranuclear ophthalmoplegia. This lesion in the medial longitudinal fasciculus, impaired adduction in one eye, abducting nystagmus in the other eye. This is basically MS's signature brainstem symptom. You may also see vertigo, facial weakness, and trigeminal neuralgia because cranial nerve nuclei and their fascicles cluster densely in the pons. So cerebellar ataxia and tremor may also be noted because MS attacks the cerebellar peduncles and the deep nuclei. So that leads to, when the cerebellum's attacked, anything that deals with gait, so unsteady gait, intentional tremor, dysmetria. So when you see limb coordination issues with dysarthric speech, think cerebellum, whether it's MS or stroke or whatever. But what you're doing is you're saying, what part of the brain controls this part of the body? So those automatic things that you do without thinking, typing, playing the piano, walking, holding yourself upright, all of those are cerebellar functions. So if something's affecting that, you think, oh, cerebellar infarct or MS or whatever. Now, some other manifestations here, which are very bothersome, are the cognitive symptoms. So MS doesn't usually cause dementia, but it does impair processing speed and attention and working memory. And that sounds like dementia, but it's not called a dementia. This reflects the loss of white matter connections, more of a disconnection syndrome than a cortical dementia. But functionally, the patient's going to tell you, I'm having symptoms of dementia. Now, fatigue is common. This is the most disabling MS symptom. This is not mood. This is not sleep. This is mitochondrial dysfunction because remember, this is an inflammatory process in a chronically demyelinated pathway. There is a condition called Uftoft's phenomena. This heat worsens conduction in the demyelinated axon. So a hot shower, fever, exercise, anything that increases body temperature can transiently reactivate old deficits. So MS is a disease of dissemination in space and time. If you see the symptoms popping up in different neuroanatomical locations across months or years, that is MS until proven otherwise. So, they may be normal between episodes, but you want to take a good longitudinal history because that's going to give you the clue. So let's talk about how we're going to manage. So remember, relapse represents active CNS inflammation causing new neurological deficits. So everything we do here is aimed at rapid immunosuppression and restoring conduction in the demyelinated pathway. So the first line treatment is high dose steroids. This is the workhorse treatment, IV methylprednisolone, 1 gram daily for 3 to 5 days. Mechanistically, steroids help in two ways. They're going to shut down that inflammatory cascade, right? So no matter where the inflammatory cascade is, steroids shut down. How do they shut down? This is your generalizable inflammation information. They quiet the T cells, they quiet the B cells, they mute the cytokines, and they reduce the microglial activation. Doesn't matter where the inflammation is, steroids are like the fire hose. They also reduce edema around demyelinated axons. So this improves conduction and can speed functional recovery. There is an oral option of 1,250 milligrams of prednisone that can be used in patients who can't get an IV. But the IV route is better and it's more tolerated. What do you think will happen when you put 1.2 grams of prednisone in someone's stomach? Bad things. Like GI upset, like hyperglycemia, like insomnia and mood activation. So you want to avoid steroids in people that have brittle diabetes or uncontrolled infection. Now, you might have to hospitalize them if they're brittle diabetes because you need to give them the steroid and the blood sugar could go out of whack. So this might warrant hospitalization. There are some steroid refractory cases. Those are the ones that get plasma exchange. Sometimes the inflammatory damage is so intense that steroids aren't enough, especially in severe optic neuritis or transverse myelitis. So why plasma exchange? Well, it physically removes the pathogenic antibodies and complement, which are the major drivers of the demyelination in MS. So usually it's 5 to 7 exchanges over 10 to 14 days, and the sooner you start, the better, ideally within 2 weeks, because then the outcome is going to be really optimized. So that should be the automatic next step when a patient shows incomplete response to steroids. There's a recovery timeline, but we want to set expectations for the patients. This is where your anticipatory guidance and counseling comes in. So motor recovery is typically the slowest. You're going to expect improvement over 2 to 4 weeks with gains to continue for several months. That can give a lot of hope. The other thing you want to talk about is sensory recovery. That usually comes back faster. That's days to weeks. So if you think about how that happens, that's generally the case, by the way, for any sort of neurological recovery. Sensory generally happens faster than motor. The other thing is vision recovery. So optic neuritis can keep improving for up to 6 months. And the big thing you need to recall here is recovery is often incomplete. So MS relapses leave varying degrees of residual deficit due to the axonal injury. And patients need this framing up front so they don't panic when symptoms don't resolve immediately. Now, there is another class of drugs. These are disease-modifying treatments when relapse means that the current therapy isn't enough. So DMTs, a relapse while on disease-modifying therapy is a failure of inflammatory control, not just bad luck. So we have to ask, how severe was the relapse? How complete was the recovery? Was there new MRI activity? And if the patient has a poor recovery or more than one relapse per year, that's a signal to escalate therapy. Usually moving from moderate agents like interferons or the like to higher efficacy agents like an anti-CD20 or S1P modulator. These are the monoclonal antibodies that we can also look at. Repeat MRIs in 3 to 6 months after the relapse to assess for inflammatory activity. So let me bottom line all this for you. Not every symptom worsening is a relapse. You can have pseudo relapses like when they're exposed to heat, infection, or stress. They temporarily impair conduction, but old demyelinated lesions. It's not new demyelination. Those would be symptoms that last less than 24 hours. They have no new inflammation and they respond to treating the trigger, not the steroid. So you'll save your patients and yourself a lot of trouble if you can make the distinction by identifying the trigger. Okay, so let's look at some of these disease-modifying therapies here, because the goal is to prevent the next one. So each DMT class works by targeting a different point in the inflammation cascade that we previously reviewed. So the injectables, the interferons, these are like the oldest therapies. They're safe, modest potency. They're interferon dampening the T cell activation, and they reduce cytokine signaling. There's another one here called galatamine, and this acts as a decoy antigen designed to distract the immune system from attacking real myelin. So these operate outside the CNS, wakening the autoimmune trigger. Relapse reduction is about 30% with these agents, moderate MRI lesion reduction, minimal effects on long-term disability, and they're good for mild or early disease, but these are not strong enough for high lesion burdens and rapid relapsers. Safety-wise, they come along with flu-like symptoms, injection site reactions, pretty low risk, so many primary care providers still think of interferon first because it's safe and familiar. Monitoring with these would be CBC, liver enzymes, thyroid function, annual MRI for disease control. Okay. Next, we move on to the oral agents. These are the disease modifying. And these medications work deeper in the inflammatory pathway. They have better efficacy, but they require more monitoring. So DMF, this shifts the immunoprofile toward anti-inflammatory phenotypes. Thymlagold traps lymphocytes in lymph nodes by blocking S1P receptors, fewer immune cells. The teriflunomide inhibits pyrimidine synthesis, which reduces the proliferation of the activated T cells. So these agents in this class are basically the muting the immune system from deploying for fresh auto reactivation. And they have slightly more efficacy, about 45 to 55% relapse reduction, 70 to 80% MRI lesions. So people like these because they feel it preserves brain. And monitoring for these are CBC and liver function for all of them, ECG and varicella serologies as well, because they are mucking with the immune system so they can reactivate. Finally, the infusions. These are the monoclonal antibodies. These are the heavy hitters in class here. Each one targets a critical point. So it's blocking the various inflammatory pathways along the way. And that's all I want you to know about those. But the upshot of all of this is choosing the right disease-modifying therapy is a benefit of risk and benefit analysis, not drug memorization. So patients with high-risk features need high-efficacy drugs early to delay escalation. And in modern MS practice, it's increasingly appropriate to start with high-efficacy therapy first and not climb the ladder along the way. In other words, we don't want to waste time. Cut to the chase. What do you have? So let's look at some of these disease-modifying drugs and how they handle the inflammation. MS debility or disability comes from chronic symptoms, things like spasticity, fatigue, pain, bladder dysfunction, gait instability. So symptom management is huge. First on your list here is spasticity. This comes from upper motor neuron lesions in the corticospinal tract. When descending the inhibitory pathways are damaged, the muscle defaults to overactivity. So the way we treat this is with things like baclofen or tizanidine, and what these are basically ways to inhibit at the spinal level to reduce excitatory neurotransmission. And in severe cases, you can use Botox for this to inject botulinum toxin, or they may get a baclofen pump to reduce spasticity. My patient I told you that had the locked-in syndrome has some lower extremity spasticity, so we bring in somebody to do Botox injections for her in her tendons under ultrasound guided, and that's kind of an adjunctive way. It buys her 3 months of pain relief without having to put her on opioids. She's immobile, so the risk of opioids is remarkably high as well. So it's good to know that you can do things locally, and this is a big NP practice in Botox, not just for beauty, but for adjunctive pain management, migraines, fibro, erectile dysfunction. Lots of reasons you can use Botox. Okay. And then non-pharmacologically, stretching, orthotics, physical therapy, and the like. Neuropathic pain. Neuropathic pain, first line treatment are going to be gabalin and pregabalin. These are calcium channel modulators. They reduce ectopic firing. Then you can move on to SNRIs like duloxetine, TCAs. These enhance the descending inhibitory pain pathways. They take longer. Trigeminal neuralgia in MS is caused by demyelination, where the trigeminal nerve enters the pons. So you treat that with carbamazepine can also be used, and then appropriate monitoring CBC LFTs along the way. Fatigue, this is not simple tiredness. I told you earlier, this is metabolic inefficiency due to the mitochondrial failure due to the demyelinated circuits. And so sleep optimization, energy conservation, there's a CBT technique called pacing, cognitive behavioral therapy technique called pacing used with chronic pain can be used here as well. Amantadine, modafinil, these things boost alertness to improve task endurance. So stimulants, off-label, obviously. But you also need to consider that this is a chronic debilitating condition. So you may develop comorbid depression and all the signs and symptoms that go with that. So it's important to distinguish those. Sleep apnea can happen, and also medication side effects are possible. So don't just assume it's MS. People with MS can develop depression as well. So that's important. MS commonly affects the spinal cord pathways coordinating pelvic organs. So this is a big deal. So they may develop bladder problems, storage problems, meaning urgency, frequency, and you could treat those with anticholinergics, but keep in mind that can lead to retention, and they can also have emptying problems. So that can cause retention, and they may require intermittent catheterization. They may have detrusor sphincter dysergia. So alpha blockers are used for that. Scheduled toileting, fiber, adequate hydration when needed. Some would say pelvic floor physical therapy might be a factor here as well, but the problem is once you lose that control, you can do all the training in the world. The muscle has no innervation, you're not coordinated. So to be considered. Mood and cognition are major issues here, especially as the white matter disconnection ensues. This is not classical cortical dementia, but depression is also common, so they may need SSRIs as well. You can get a 2-for-1, put them on an SNRI, and you can get mood and pain control at the same time with like a duloxetine or something. That's a handy way to reduce polypharmacy. Cognition process speeds are lower, so SNRIs are good for attention and cognition and attention. Executive function can be enhanced, but they do raise the blood pressure, so you make sure you don't want to increase stroke risk in the process, so make sure you're monitoring for that as well. So don't underestimate how much cognitive rehab can improve quality of life. It's not all pills. Gait problems arise from cerebellar lesions and motor tract weakness and sensory ataxia. So you want to evaluate and refer to PT, and they may need orthotics or assist devices in some way. So physical therapy for strength and stretch is useful. Symptom management has to evolve as the disease devolves. So you reassess regularly and always address treatable and reversible causes before adding medications. All right, let's walk through a case for multiple sclerosis here. So you're the NP seeing this person in clinic or the ER, and your job is to connect symptoms, MRI findings, and CSF profile to the underlying multiple sclerosis biology. So what you have is this 28, everyone's 28 today, a 28-year-old woman. And what's going on here? We'll take a quick read. The patient has acute right eye vision loss and pain with eye movement. That is the classic optic neuritis. Now, this is pain with movement, and it tells you that the optic nerve sheath is inflamed. She also reports a previous episode of left leg numbness and tingling that resolved. So this is a red flag for a prior demyelinating event. So you have RAPD on the right and color desaturation. So what you're seeing is otherwise normal fundus as typical in optic neuritis is retrobulbar. So mild hyperreflexia in the legs further supports this central nervous system involvement. And so likely there's some spinal cord involvement here. So we go to the MRI. And what do you do first here? Well, her MRI brain shows multiple T2 flares and hyperintensities in the periventricular, juxtacortical, and infratentorial areas. You've got two lesions that enhance, meaning they're reactive, and others don't, meaning older. So her cervical spine has two lesions at C3 and C4. And this is classic dissemination in space. So this is exactly the pattern MS lesions prefer. Regions where oligodendrocytes are abundant and immune trafficking is common. So then we do CSF. And what does the CSF show? Well, it shows mild lymphocytic pilocytes, and this is consistent with autoimmune inflammation. And you'll see protein at 45 milligrams per deciliter. That's mildly elevated. You might see oligoclonal bands. That's present in the CSF, but not in the serum. You see IgG, which is the 0.9, and that's elevated. You don't need to know the numbers. If there's numbers, the lab slip will tell you. So this confirms intrathecal IgG production, one of the strongest biomarkers of MS. So does she meet McDonald criteria for MS? Yes, absolutely. And you can look up what that McDonald criteria is. I deleted it because it's extraneous, but suffice it to say, these are scoring tools to tell you how far along are we. We have dissemination in space, and that definition is it requires lesions in greater two or more characteristic regions, right? She has that. Paraventricular, juxtacortical, infratentorial, spinal cord. She has all four. And dissemination in time can be met because she has simultaneous gadolinium enhancing and non-enhancing lesions, or she has CSF specific oligoclonal bands. She has both. So she meets full McDonald criteria of time and space on this visit. So you can diagnose her now with MS and not wait for another clinical event. And why would you do that? Well, because we want to deal with prevention. So deal with the optic neuritis. This is a true relapse. She needs high dose steroids, right? IV methylprednisolone. Consider the oral taper. And then if severe vision or poor response, then plasma exchange. And then finally, when should you start the DMT and which ones? You're probably not. You're going to refer her to a specialist. But delaying treatment tends to lead to irreversible axonal loss. So you do want to start them sooner than later. Age is younger, so push for higher efficacy. High lesion burden, she has it. Spinal cord involvement, present. Active enhancing lesions, yes, she's got that. Rapid relapse onset, yep, 2 events within 8 months, she has that. This patient is not a candidate for mild therapy. She should start the high efficacy DMT sooner than later. Those will provide the best chance at relapse prevention. Question number 4 here. What prognostic factors would you discuss? She has several poor prognostic markers here which justify early aggressive treatment. So what are they? Younger age onset, optic neuritis plus spinal cord involvement, high T2 lesion burden, early enhancing lesions, positive OCBs, short interval between demyelinating events less than 12 months. These factors predict faster disability accumulation without treatment. So you emphasize here what? Good news, with early initiation of high efficacy DMT, her long-term outcome can be dramatically improved. So we need to get her to care. All right, so let's pull all this together here. So this is your end-to-end reasoning, how to diagnose MS, treat the relapse, and choose the DMT. So the diagnostic confirmation is this McDonald's criteria. Mechanistically, the patient meets this, right? Dissemination in space, or MRI shows a lesion in the periventricular white matter and the juxtacortical areas and the infratentorial lesions, the spinal cord. Those are the 4 distinct CNS compartments that dissemination in time require. She has simultaneous gadolinium enhancing lesions. She has a non-enhancing lesion. That's what tells you it's old. And she satisfies the DIT criteria. She's got CSF oligoclonal bands. So acute management, steroids, select her for the DMT medications. There's high efficacy for her. The younger you start, the better it is for her, because we want to prevent future relapses. I don't know what this is here. Okay. All right. Let's move on now to peripheral neuropathy. Okay. So, so peripheral neuropathy is is it dangerous? Is it systemic? And what's the underlying pattern? Peripheral neuropathy is not one disorder. This is a syndrome with a limited vocabulary. So patients will describe to you numbness and tingling and burning or weakness. Your job is going to be to decode which part of the peripheral nerve is failing and why. And the first major division you need to think about in peripheral neuropathy, the one that drives your differentials, your labs, and your EMG, is understanding whether this is axonopathy or myelinopathy. So axonopathy means you have damage to the nerve fiber itself. Think things like metabolic, toxic, nutritional, systemic disease. The clinical pattern here is there's a length-dependent stocking glove, slowly progressive presentation. So what happens in axonopathy is the longest axon fails first. Think of things like classic diabetes or chemoneuropathy. If this is a myelinopathy, damage to the insulating sheath around the axon, that's when you think this is an immune-mediated or an hereditary demyelination. And the clinical pattern for a myelinopathy is they present with weakness out of proportion to the sensory loss, an areflexia, and there's a rapid progression. So the pathophysiology of a myelinopathy is there's a conduction block and the signal fails to travel. The thing that will tell you this is the electrodiagnostics, EMG and a nerve conduction study. These don't just confirm the neuropathy, they tell you which structure is injured, and that's everything. It determines whether you replace a vitamin, stop the toxin, immunosuppress the patient, or send them to the ED because they're having Guillain-Barré syndrome. So the entire goal of this section is going to be to help you realize the clinical patterns and predict likely pathology so that you can order the right electrodiagnostic test and treat the underlying cause, not just the symptom. So if the seizures were about cortical hyperexcitability and MS is about inflammatory demyelination, peripheral neuropathy is about wiring failure. And your task is going to be to figure out whether the wires are frayed, stripped, or dying altogether. All right, let's go. All right, so let's slow this down and take a look under the hood. Let's see these peripheral nerves. So almost every neuropathy you're ever going to diagnose is going to fall into one of two buckets. It's either going to be axonal injury or myelin injury. And once you know which structure is failing, then the entire picture comes into focus. So if you have an axonopathy, that's the wire itself is dying. So think of the axon as the copper wire inside a cable. In axonopathies, the wire is degenerating from the far end first. That's classic dying back pattern. Why distal first? Because the longest axons have the highest metabolic demand. They need mitochondria, ATP, axonal transport running nonstop. So metabolic and toxic injuries like diabetes, alcohol, chemotherapy hit the longest fibers first. And the clinical pattern you're going to see are going to be length-dependent stocking glove numbness, sensory loss, which precedes weakness. The reflexes fade distally. And when you do the nerve conduction study, what you're going to see is low amplitudes because fewer axons are firing. You'll see normal conduction velocity because the myelin is still intact. So this is the nervous system quietly telling you signal strength is weak, but the wiring insulation is fine. Whereas in myelinopathy, the insulation is damaged. So here, the axon is structurally intact, but the Schwann cell and myelin are compromised. Myelin is the insulation that allows a salutary conduction. That allows jumping from node to node. So when you strip away or disrupt that insulation, the nerve becomes electrically inefficient. So what happens is you get this segmental demyelination, which causes conduction block or slowed transmission, and then the signal arrives late or not at all. The nerve becomes fatigable. So what is the clinical pattern? Well, they typically will start with weakness and then proceed to sensory symptoms. There's an areflexia. Okay, that's often very striking. There's a proximal and distal involvement. This may evolve rapidly in something like a Guillain-Barré or a chronic a CIDP, chronic inflammatory demyelinating polyneuropathy situation. So the nerve conduction study finding will show you normal amplitudes. That means axon is preserved, but slow velocities and prolonged latencies. That means myelin is lost. So here the nerve is telling you the signal strength is normal, but the insulation is failing. So what do you take home from all this? Axonopathy means metabolic or toxic. That's distal symmetric and low amplitude. Myelinopathy tells you immune hereditary, which is multifocal and proximal and slow velocities. And most importantly, the pattern is telling you the story before the EMG ever does. So listen for the story. Mixed patterns are common. So diabetes with superimposed CIDP, chemotherapy, neuropathy with inherited issues. So keep both in mind when the presentation doesn't fit normally. So if you hear a story of both, right, that's CIDP, that could be diabetes, that could be chemotherapy. But one or the other, that's a clean story. So now you know typical pattern for axonopathy, myelinopathy, and now you know the triggers for mixed conditions. So whenever you're evaluating a neuropathy, don't start with labs, start with pattern recognition because the neuropathy isn't one disease, it's a series of predictable signatures. So the 7 questions you need to ask are the scaffolding that gets you to the right diagnosis before the EMG, before the labs, before anything else. First question, what's the pattern? Map the disease. This is your biggest diagnostic lever. So if the symptoms march distal to proximal, that's a length-dependent axonopathy. Think diabetes, toxins, or chemo. If the pattern is patchy, painful, asymmetric, that's a mononeuritis multiplex. Think vasculitis until proven otherwise, and think symmetric versus asymmetric. That isn't just a detail, you're getting the diagnosis as they give you these clues. The other thing you want to ask is what modalities are affected? Is it sensory versus motor versus autonomic? So modalities tell you what part of the nerve is under attack. If you have a motor loss, think immune-mediated, Guillain-Barré, CIDP, hereditary. If you have sensory pain and paresthesias, that's the classical metabolic toxic axonopathy. And if you have autonomic dysfunction, well, that could be things like diabetes, amyloidosis, autoimmune ganglioplasty. Neurons are organized, and then the failure pattern will reflect that. So what is the time course? Well, the clock is also diagnostic. So time course is almost pathognomonic. If it's less than 4 weeks in duration with symptoms, that's typically Guillain-Barré or vasculitic neuropathy. If you're in the subacute 1 month to 6 month phase, that's probably toxin exposure or nutritional deficiency. If you're chronic, meaning greater than 6 months, that's probably diabetes, hereditary neuropathies. The nervous system is not lying about their tempo. The other question is family history. Do you have a family history? Genetics matters more than we think. So, age of onset, ankle surgeries, high arches, clumsiness in childhood, those are all CMT clues. Hereditary neuropathies are often masquerades. He's just always been that way. Ask explicitly, don't just assume. You can also have some associated symptoms, the non-neurologic breadcrumbs, we call these. These guide you to underlying etiologies. So, for example, is it associated with weight loss? Oh, do you have cancer? Is this a paraneoplastic syndrome? Rash. Might this be vasculitis? Joint pain. Is this an inflammatory disease? Gait patterns, ataxia, step gait tells you sensory versus motor failure. The peripheral nervous system does not exist in isolation. If they're having systemic signs that point to the root cause, pay attention. Other things to consider are things like medications and exposures. Toxins can often masquerade as neuropathy. So some of the worst neuropathies come from our own treatments, like, say, chemotherapy. Antibiotics like metronidazole and nitrofurantoin can cause it, neuropathy. Alcohol and organic solvents can cause it. They can cause chronic axonopathy, especially with chronic exposures over time. So always ask, what changed before the symptoms started? What were you doing? Or where were you living? The other thing to ask about is systemic disease, where neuropathy is a symptom, not the diagnosis. So neuropathy is often downstream of something bigger. Diabetes is probably the most common driver, but also can be thyroid dysfunction, renal or hepatic failure, connective tissue disease. All of these conditions can poison the nerve from the inside out. So the big thing is not memorize, but look for ways to elicit pattern recognition so that you just don't do blanket testing. In the modern age that we live in, if you come in with any one of these symptoms, you're going to get referred to a nerve conduction study, an electromyogram. And that's how they're going to tell, because we don't believe that patients will tell us a good story. So you now know the history to take to build a case on the way to the nerve conduction study. Okay. So now that you can recognize neuropathy patterns, the next step is simple. So what's simple about any of this? Well, what's damaging the nerve? Is it the axon or the myelin? Well, the first bucket is metabolic causes. These are slow, chronic injuries that starve or poison the nerve over time. So diabetes, chronic hyperglycemia leading to microvascular ischemic changes, sorbitol buildup. So the longest axons quietly die back. That's the classic stocking glove. B12 deficiency is another one you can think of when you lose proper myelin maintenance. So you get this demyelination of peripheral nerves and the dorsal columns. Vitamin E deficiency, you can lose antioxidant protection, so you're more subject to oxidative stress, and that hits the long axon, and patients develop a sensory ataxic neuropathy. You could be folate and thiamine deficient because energy metabolism fails and the distal axon degenerates from the metabolic exhaustion. You could be B6 deficient. Too little impairs neurotransmitter synthesis, and too much is directly toxic to the sensory ganglia. So either way, you can get a sensory neuropathy. Toxins and medication is the second bucket here, where you can have iatrogenic or under-recognized causes. So alcohol is a double hit because malnutrition plus a direct mitochondrial toxicity in the axon leads to this symmetric distal axonopathy. So how do you get alcoholic neuropathy? If I ask you about that, here it is, the malnutrition plus the mitochondrial toxicity. Well, what about chemotherapeutic agents? Right? These injure the dorsal root ganglia, and then you get microtubule disruption and DNA damage, and that causes severe sensory neuropathy. What about amiodarone, all the rage? This accumulates in Schwann cells and lysosomes and produces a demyelinating picture on the nerve conduction study. Metronidazole, this generates free radicals and impairs the mitochondria, which can injure the axon. What about TB treatment when we put them on isoniazid? Well, isoniazid, INH, depletes B6, so GABA synthesis and nerve function suffer, leading to sensory neuropathy. Unless you supplement. That's why when we put somebody on INH, we always put them on co B6 with them. What about statins? Statins reduce CoQ10, which impairs mitochondrial ATP production in muscle and nerve. That's how come when someone goes on a statin and they say they're fatigued, they're not hallucinating. There's a legitimate reason, which is why we may put them on CoQ10 alongside the statin therapy, because statins reduce CoQ10, which reduces mitochondrial ATP production in muscle and nerve. What about heavy metal exposure? Things like lead, arsenic, mercury. All of these cause direct axonal toxicity and disrupt axonal transport, giving a mixed sensory neuropathy. But wait, there's more. Inflammatory immune mediated. This is the third bucket of things that can cause you neuropathy. So here, the immune system mistakes a nerve as a foreign invader and attacks either the myelin or the axon or the blood supply. So then you can have neuropathy that way. Guillain-Barré syndrome. These are where antibodies target the myelin or the axonoma, causing acute demyelinating or axonal neuropathy with a rapid ascending weakness. What about CIDP? Well, CIDP, this is a chronic cousin of Guillain-Barré. An ongoing immune attack on the Schwann cell produces segmental demyelination and slowed conduction over months. We can, of course, have vasculitic neuropathy, inflamed versus nervum, cut off the blood supply. So then what happens? Well, the individual nerves infarct, and you see painful asymmetric mononeuritis multiplex. And what about paraneoplastic neuropathies? Well, these are anti-neuronal antibodies like anti-Hu, which attacks the dorsal root ganglion neurons. And then what happens is you create a sensory neuropathy that may precede a cancer diagnosis. There's a fourth bucket, which is the hereditary causes. These are wiring defects, present for life, but often only recognized in adulthood. There's Charcot-Marie tooth disease. This is a mutation in myelin or axonal proteins, which slowly weaken distal nerves, producing progressive foot drop, high arches, and distal sensory loss. There's also familial amyloid polyneuropathy. This is a misfolded transthion deposit around the peripheral nerves, which causes axonal loss with prominent autonomic symptoms like orthostasis and early satiety. So what did I just describe to you? Oh, look, a systemic symptom with a complaint of neuropathy. When you have the two together, you're immediately thinking, this is not the usual horses. This could be a zebra. I should think to look for something else. One of the biggest problems in practice is failure to diagnose. And the reason you fail to diagnose is because you don't ask enough questions and you don't connect enough esoteric things. This gets easier with AI because you can punch symptoms into like open evidence or Doximity and say, what are my differentials? Expand them. What am I missing? Help me rule these out. So you can really offer the patient a good map. The problem is the AI output is only as good as the input. So you need to take a really good history to make sure you're putting in a good prompt that covers all their symptoms so you can hopefully get this. I'm not expecting you to memorize all of these at all. I just want you to listen for patterns to know what's typical versus atypical. And that's all I'm looking for. So don't get overwhelmed by the list of things I'm giving you here. This is all to put everything on your radar so that when you're listening, you're like, oh, I think I heard that somewhere. Let me go talk to my AI chatbot and I can look things up. The worst thing you can do is say to a patient, I have no idea and I don't even know where to look. Bad. I need you to at least know where to look or at least know what question to ask because you're at least educated, supposedly more informed than they are. So you've been educated. Thank me. Let's move on to this case study here. Now, diabetic peripheral neuropathy. This is very common in primary care. You'll see a lot of this. So we have this 62-year-old man with a long-standing type 2 diabetes and a slow progressive onset of numbness, burning, tingling in both feet. And the key phrase here is 8 months of worsening symptoms. This is chronic, not acute. And the distribution is classic: bilateral, stocking glove, sensory loss, etc. His exam fits perfectly. Loss of light touch, pinprick, that's why you do the monofilament test early and often, to the mid-calf, absent ankle reflexes, preserved strength, and mild intrinsic foot atrophy. That pattern of distal sensory loss, diminished reflexes, preserved proximal strength, those are almost all diagnostic of length-dependent axonal polyneuropathy. Glycemic control is poor. Lo and behold, the A1C is 8.6 and fasting glucose is 188. That is plenty of metabolic stress to injure the longest axons. Now let's look at his electrodiagnostics. So reduced amplitudes, absent sural response, and fibrillation potentials in the distant muscles. Okay, amplitude loss means axon loss. Fibrillation potentials means active denervation. So the nerve conduction study EMG is telling us this is a sensory motor axonal neuropathy, exactly what diabetes produces. And here's the pathophysiology in one sentence. So you get chronic hyperglycemia injures the vasa nervum, starves the axon of oxygen, and drives distal to proximal axonal degeneration. The longest nerves take the first hit. That's why the feet go before the hands. So, this question 1, diagnosis and mechanism. So this diabetic distal symmetric polyneuropathy caused by metabolic and microvascular axonal injury. Question 2, what additional labs would you consider? Well, we confirm the neuropathy pattern, but we still screen for other reversible contributors. So what do you screen for? B12, TSH, SPEP, monoclonal gammopathy, renal function, B6, folate levels, if the presentation is atypical. All of these have been covered in previous lectures, but you can see now how it's all coming to play. Question 3, pain management. What's first-line therapy in this pain management cascade here? Well, gabapentin or pregabalin. Options also include duloxetine or TCAs, depending on the comorbidities and tolerability. If you do a TCA, check for cardiac and make sure you check the QTC so we don't enter the QTC prolongation problems. The real anchor of treatment, though, is going to be what? Improving glycemic control, because the medications treat the pain, but the glucose control is what's going to slow the progression. Now, they normally don't complain about any of this until it causes erectile dysfunction. And then they do everything, but at that point, it's kind of late. So, what now? What preventative measures and patient education would you recommend? Check your feet every day. Make friends with a podiatrist and see them every 6 to 8 weeks. Proper footwear, avoid walking barefoot, explain that neuropathy is progressive and silently you will develop foot injuries that will go unnoticed and they can get infected, and reinforce good glucose control is the only intervention that slows the underlying nerve damage. So, all right, here we go. Let's finish this up nicely. So, what we talked about today. We talked about ischemic stroke, right? This is time is brain. Every minute without blood flow costs about 1.9 million neurons. So your operational target is door to needle in under 30 minutes. The penumbra is still salvageable and the core is already dead. So your job is to keep the penumbra from converting to core. And what forces you to escalate? Large vessel occlusions, posterior circulation strokes, and or worsening new National Institute of Health stroke severity scale. Those patients need mapping and rapid imaging and early thrombectomy if they have a large vessel occlusion. Then we talked about seizures and epilepsy. So for seizures, you always want to match the anti-epileptic mechanism to the seizure type. That's the fundamental clinical reasoning. So monitor levels because they have narrow therapeutic indices on all of those anti-epileptic drugs. And don't forget to talk about counseling on driving restrictions and pregnancy planning and oral contraception if you're going to put them on something teratogenic, which you should avoid in women of childbearing age. The escalation triggers are this. If they have status epilepticus or a drug-resistant epilepsy, that's when you need a higher level of care and subspecialty input. With respect to multiple sclerosis, in MS, the key thing to keep in mind is early disease-modifying therapies because they can alter the disease trajectory. Don't wait. Treat the relapse within 5 days for best recovery and always address the patient's day-to-day symptoms. Quality of life matters. When do you escalate this? Any breakthrough disease, new lesion, new symptom, or progressive decline despite treatment. Now, what about peripheral neuropathy? Well, for neuropathy, the magic phrase is pattern recognition. So how do you decide whether it's axonal, demyelinating, asymmetric, length-dependent, or toxic? Target the modifiable contributors: diabetes, B12 replacement, toxin removal. Choose pain meds based on the mechanism, and escalation is triggered by any red flag, like acute onset, asymmetry, rapid progression. Those patterns suggest an inflammatory vasculitic neuropathic. This is not routine diabetic neuropathy. And finally, there's the overarching message that I need you to remember for all of this. Neurological assessment is dynamic, it's moving, it's targeted, not a snapshot. So serial exams tell you far more than a one-time visit. So make sure you're documenting trends and watch for changes. Let the pattern guide your management. All right, let's quickly review these stroke red flags here. First, you need to talk about atypical timing, atypical location, or atypical presentation. Wake up strokes. MRI becomes your tool. CT won't help you time the lesion. Posterior circulation, you need to think about ataxia, vertigo, dysarthria without weakness. Don't miss these. Cryptogenic strokes are those that happen under age 55. Always evaluate for PFO and hypercoagulable states, the ones we talked about in the hematology lecture. Fluctuating deficits, that's a TIA pattern. Make sure neurology is involved early. Seizure red flags. Well, red flags for seizure are about ruling out dangerous mimics and locating the focus. Focal onset neuroimaging is required always. Todd's paralysis can look like a stroke, but remember the context. Status epilepticus. If EEG is clean, consider PNES, not epilepsy. And new onset seizure in older adults, think malignancy until proven otherwise. With respect to MS red flags, when it comes to MS, your red flag tells you maybe it's not MS. So if you have progressive from onset, consider NMO, MOG, or metabolic causes. MS rarely starts this way. Poor steroid response, that's very suspicious. Encephalopathy, not typical for MS. Symmetric symptoms, MS offers focal disease. So you're looking, if the atypical presentation, it may not be MS. What about the neuropathy red flags? Well, for neuropathy, your red flags help you distinguish from time-sensitive pathology. So acute or subacute. Guillain-Barré, vasculitis, toxic exposure. Asymmetric pattern, consider mononeuritis or vasculitic until proven otherwise. Autonomic involvement, think amyloidosis or longstanding diabetes. Painful small fiber pattern, screen for diabetes, amyloid, connective tissue disease. These red flags are pattern interrupters, so your brain should immediately shift gears when you see them. They help you decide who needs imaging and who needs labs and who needs escalation neurology right now. We did it. All right.